Good evening, everyone. Welcome to First Aid AMC MCQ. I am Dr. Arshan Ahmed. I'm going to be your coordinator for the next 5 months AMC MCQ course. For those of you who don't know about me, I have been working in Australia for quite a long time, and I have experience in both hospital system as well as general practice. So I have ideas about anything or any questions that you might have in your head. We have been helping the IMGs for the last 7 years. And every year that we have been helping the IMGs to pass their MCQ and clinical exam. Almost every year we had a huge amount of candidates who passed their exams from us. We can't even remember those names when we started, but we know that the students who started with us, now they're working in Australian health system. Many of them are now registered in here. So why I'm saying that every 5 months we take this MCQ course, and this is just a start of your journey to be a doctor in Australia. And we are proud to be a part of your journey. And I can assure you that when you are a part of First Aid AMC, you'll never feel that there is lack of anything in here. You always feel connected to us. You feel connected to the students who are also in the course, and you make friends who might be your best friends for a long, long time. AMC preparation, it's a long journey, but with appropriate guidance, with appropriate materials, it can be made quite easy. But you need to have that guidance with you. Otherwise, you will end up wasting a lot of time as well as a lot of money. We always get lots of students from other courses from where they thought that that's the ideal course for them, but they did not get satisfied with them. And then they come to us and they say that, doctor, I have failed 3 times in MCQ. I've heard about your course from someone, so I want to give it a try. And I still remember just in the last month, in February exam, there was a candidate who failed 3rd time in her exam. And then she joined our course, the last course that we have finished, and she passed the exam on her 4th attempt. So we are part of a lot of IMG's dream, a lot of their journeys. And many of you who start with us, you actually pass your MCQ exam, then you enroll into our clinical course, which is a very highly recommended course. You might have heard about us. Then again, after passing clinical exam, you actually become a doctor in Australia. So your journey starts with us and it also ends with us. So this is how we take pride in us. And we can assure you that First Aid AMC MCQ has everything that you need to pass this exam in your first attempt. You don't need to go for 3rd, 4th attempt for MCQ, because if you can't pass MCQ in first attempt, that's actually a waste of time, because you are supposed to. If you know what to read, if you have that guidance behind you, you should pass it in the first attempt. So tonight, I'm going to show you how we take our classes, and you will get to learn about us. And I hope that you will also enjoy the class. Enjoying the session is very important, because if you don't feel interested, taking a class doesn't mean anything. It's just a waste of time. After end of this class, we will go through the discussion about the course, about the details of each and everything that we are going to cover in this 5 months MCQ class. And again, you might be thinking in your head that why 5 months? Why not just 1 month preparation? I have heard from one of my friends that She just prepared 1 month and she passed the exam. Why I will prepare for 5 months? That's a question I always answer in this way. If your friend told you that she passed with just 1 month preparation, she just lied to you, because it's not possible. You will not be able to even understand about MCQ within 2 months of your preparation. That's how it is, because it's totally new. You are working in your country, and we get people from all over the world, doctors from everywhere who join the course, and everywhere the guideline is different. So how you are going to get even an idea about Australian guideline within a month? It's not possible. I always say that you need at least 2 months even to understand what is MC MCQ. And after 2 months, then you start to understand that this is how I am supposed to read. That's why I always take a course which is 5 months, and where you can at least understand everything that you need for this preparation. We could always take a course which is 2 months or 3 months, and it's better for us because we can take at least 6 or 5 to 6 course in a year. But we don't do that because we take care of you so that you learn from us everything that you need, so that you don't need to go through anything else. That's the reason. And you get a prolonged access to our notes and video recordings even after finishing the course. So we will go through that in a bit after the class is finished, and you will learn a little bit more about us. Okay, now we usually keep you muted during the class. It's just because sometimes we see some surrounding noise coming from doctors who are not aware that their microphone is on, and it disrupts the class. So feel free to ask anything on the chat box in Zoom, and I will always answer you over there. All right? So you guys are ready to start? You guys can hear me properly? No problem so far? For those of you who are in Facebook, I have kept the Facebook open beside me. So if you have any questions, feel free to write it on the comment section. But try to join the Zoom session because that becomes easier, and we always take our sessions on Zoom, not on Facebook. Facebook is just because of this initial trial class and also the 2 weeks free sessions. We will do it both on Zoom and Facebook just for your better convenience. All right. For those of you who are in Zoom, you guys can hear me properly. Great. Let's start then. So first of all, we will go through a little bit about MCQ format. So you might have already known about a little bit what this AMC MCQ exam mean. So AMC MCQ is also known as AMC Part 1. It's a computer adaptive software based exam, which means that you will need to go to the exam center and you will be given a computer, and on that computer you will have 150 questions, which is about 3 hours in duration, and the past score is 250. So the only issue with AMC MCQ is that no one knows which question carries how many marks. So one question can carry just 2 marks, the next question can carry 10 marks, but you don't know about that. So that's why 150 question is marked as 500. Out of 500, if you get 250, your AMC score comes like this. So you can see that it's a 0 to 500, and the middle is your passing score. So if you get 250 and above, you pass the exam. Unfortunately, we never know which question carries how many marks. Out of this 150 question, there are 20 questions, which is pilot question. Pilot question means that it's a non-scored question. Again, you never know which one is pilot question. So every question that you get, you will think that that's a scored question, but among them, 20 questions will be just a non-scored question. But one of the other important thing is that out of this 150, the last 20 questions that you get in your exam, so from 130 to 150, that 20 question is never a pilot question. That's why I always say that the last 20 question is your best bet, which means you have to make it right. And those 20 questions carry more marks than the other questions, because AMC knows that most of you will run out of time by the end of the exam. So those 20 questions are non-pilot and those carries good marks. It's a software-based exam, which means no question is similar. So the person who is giving exam beside you, his or her exam set is totally different than yours. How the software gives questions to you, it depends on your level of knowledge and also your level of answering the question. Let's say you answered one question correct, which was just a simple question which carried 2 marks. Software will give you the next hard question. So your second question will be a little bit hard. So you get maybe a 4-mark question. You still got right in this second question. Software gives you third question, which is more harder. So every time you correct your answer, software gives you a little bit hard question. Now, you might be thinking that if I get a lot of questions right, I will get a lot of hard questions. I will fail the exam. It's not like that. We have seen that people who get hard questions in the exam, they pass more than someone who gets all the easy questions, which means that most likely that candidate did not get hard questions at all because he or she did not even get into those questions because they could not even make the simple questions right in the exam. All right, so it's not a bad sign that if you get a lot of hard questions in the exam. So don't get over-stressed in the exam if you get a lot of hard questions. All right, so that's an idea how the AMC MCQ usually happens. The subjects or topic that you are supposed to learn for MCQ preparation is medicine, surgery, gynae and obstetrics, pediatrics, psychiatry, which is one of the vital topic for your AMC preparation, and biostat populations that comes under this. So they have given a general idea how much percentage of questions come from these groups. Medicine usually has the highest percentage, then surgery, and then others are more or less same. But AMC never usually follows this percentage. Many of you will get a lot of questions from psychiatry, not a lot of questions from medicine. On the contrary, some of you might not get too many questions from psychiatry, you might get a lot of questions from medicine. So it's a totally your luck how your questions come in the exam. All right. Tonight we are going to mainly focus on psychiatry. This is our psychiatry class 1. Doesn't mean that this is the finishing of psychiatry. Psychiatry, we take 3 to 4 classes. But for the trial session, we are focusing on the most important psychiatry topic that can appear in your exam. When we start reading the psychiatry, the books that we are supposed to follow is JM 8th edition. So there is no longer 7th edition we follow. So we follow the 8th edition. Kaplan Step to CK. The website you can follow is Rand CP Medscape. If you ask me which book I am supposed to read for psychiatry, I will say that Kaplan Step to CK will be your first and foremost book that you are supposed to read. So Kaplan Step to Psyche will give you a general idea and basic idea about the psychiatry topic. After you read the Kaplan Step to Psyche, there is a book called U-World USMLE. U-World USMLE has a lot of questions about a particular topic, like we are discussing depression. U-World has depression-related questions. You are supposed to solve those questions and go through the answer explanation. That gives you a very good knowledge on psychiatry. If most of you never ever read psychiatry in your medical university or college, that's why Australian system, they know about it, that many Asian countries don't go through psychiatry in their curriculum. Even if you do, it's a very minimal. So that's why they make the psychiatry a little bit harder. And for you who doesn't have any idea, it's already harder. So to get a basic knowledge on psychiatry, U-World USMLE will be your friend. Once you have done that, our lecture note has almost everything that you need for your preparation. And we will also do some question solvation based on psychiatry. We'll give you some Q bank from where you can solve the psychiatry-based questions. And once you have done that, in our portal or in our software, we have psychiatry mock test. You will go through that mock test and find out how well you are doing in the mock exam. If you do good, it means you have a very good psychiatry preparation. So that's how we always do throughout the course. This is the way of our learning. So you do the theory lecture with me, you solve questions with me, and after that, we give you some Q bank, we give you other things to read, and after that, at the end, you go for a mock exam. We will discuss about the mock exam, which is totally similar like AMC MCQ exam in your real scenario. So our software has almost 50 to 70 mock exams so far. And all of them, some of them are subject based, some of them are monthly question based, some of them are grand mock test, which has full mock test, like 150 questions. So as part of the course, you will be able to solve those questions, and also you will be able to find out about your preparation. Okay, so moving on to psychiatry. If you have any questions, if you don't understand anything, please feel free to write it in the chat box. Starting with the depression. So if you are wondering from where we have taken the lecture notes, the lecture note is a combination of Kaplan Step to Psyche and John Muttag. So this is the main two areas from where we have taken all the lecture. Okay. So starting with the depression. Major depressive disorder. A 70-year-old woman was recently admitted after her son informed the doctor that she had been doing very poorly over the last few months. Patient reports 30-pound weight loss, decreased concentration, feeling of helplessness and hopelessness, decreased energy, decreased mood, and decreased sleep. So that's how usually MDD patient presents. So how to diagnose major depressive disorder? DSM-5 criteria says that if a patient has 5 out of these 9 symptoms and at least for 2 weeks, that's major depressive disorder. So you can see there are 9 symptoms. Out of the 9, if someone has got at least 5, among these 5, 1 or 2 should be there. And if it persists for at least 2 weeks, that's major depressive disorder. So what are these 9 symptoms that we have got? We follow the mnemonic called M-SIGE-CAPS. So M for mood changes, so patient can have a low mood, irritable mood. S for sleep changes, so patient can have insomnia or hypersomnia. I, loss of interest, which is what we call as anhedonia. So low mood and anhedonia, these are the two most important symptom to diagnose major depressive disorder. G for guilt, E for lack of energy, fatigue, tired, C for loss of concentration, loss of attention, A for loss of appetite. Some people can get increased appetite. P for psychomotor changes. Psychomotor changes can be either psychomotor retardation or psychomotor agitation. Which one is common? Retardation. So major depressive disorder patient will say that I feel I'm slowed down on everything. So patient will be slow everywhere. So that's what we call as psychomotor retardation. Agitation, if patients say I am very hyperactive, I feel very agitated, that's psychomotor agitation. And lastly, S for suicidal ideation. If a question asks you that what is the most important symptoms that you will ask in a patient with depression, what are you going to do? Guys, so if the question asks you that what is the most important questions that you are going to ask in a patient who has depression? Very good, Dr. Sadman. Suicidal ideation or suicidal tendency, suicidal thoughts. So that's the most important symptom that you will look for. So that's your DSM-5 criteria. You can go through that. You can see that the weight change of appetite can cause loss of weight in this patient as well. After that, the two major criteria that you need to diagnose major depressive disorder, one is depressed mood and another is marked loss of interest, otherwise known as anhedonia. So question can ask you, what is the two key criteria, or which one of the following is the most key, or they can ask that which one of the following is the key criteria to diagnose a patient with major depressive disorder. In that case, you are going to look for either depressed mood or loss of interest. If both of them are in the question, which one is more important? Depressed mood, followed by loss of interest. DSM-5 also divided the depressive disorder into some other subtypes. One of the subtype is this major depressive disorder that we have just learned about. Then there are disruptive mood dysregulation disorder, not important. But this one, persistent depressive disorder, PDD, this is important. So what is this persistent depressive disorder? Persistent depressive disorder is a long-standing depression of mild severity, which persists for 2 years or more. So if someone having a mildly severe depression, which is persistent for at least 2 years, that is what we call as PDD. Coming back to major depressive disorder, it is divided into mild, moderate, and severe based on the features. And understanding how to differentiate mild, moderate, severe helps us to find out what is the best treatment for the patient. In a simple sense, we say that mild to moderate means patient is not seriously unwell, and most importantly, patient doesn't have any active suicidal thoughts. If someone has got active suicidal thoughts, so severe means active suicidal thought, as well as if a patient having depression with psychotic features. This too is usually termed as severe depression, and for severe depression, the treatment is little bit different than mild to moderate depression. We will come to that point in just a few minutes. Now you might have seen this two line, psychotic features has the worst prognosis. So if someone who has major depressive disorder, she is saying that, doctor, I can also see someone who is talking to me, but I can't actually see that person. I can hear the voices. So if someone is seeing something or hearing voices, that means they are having hallucination delusion. If a patient having hallucination, that means depression with psychosis. If a patient having delusion, which is a false belief, like if a patient with depression think that he or she is the person who is guilty about someone's death, or he or she is the person thinks that someone is trying to harm them by poisoning. So this kind of delusional belief also indicates patient having psychotic features. So a patient who has depression with psychosis has the worst prognosis, termed as severe depression as well. MDD patient can have some atypical features. These are the three atypical features you can get. One, they can have increased appetite followed by increased weight, and they can also have increased sleep. Whereas most commonly, you are supposed to get lack of sleep and loss of weight and loss of appetite in a depression patient. But atypical features can be there. Before we go into the treatment, let's understand a little bit about how depression presents in a child or adolescent. It's a very tricky area because children doesn't present like adult. Adult come to you with feeling low, feeling depressed, and loss of interest, all the good symptoms or all the character get in adult. But in case of children and adolescent, they don't come to you with feeling depressed. Rather, they come to you with feeling very angry, feeling irritable, agitated. So you can see here, major depression in children may be diagnosed using the same criteria as for adult, like loss of interest and presence of sad or irritable mood persisting for 2 weeks or more. In children, irritability may be more prominent than sadness. So irritable child, maybe underlying reason is depression. What else you can get? Very commonly, children has feeling of helplessness, worthlessness, despair, difficulty in sleep, not enjoying meals, poor concentration, low self-esteem. Sometimes they will say that they don't want to go to school or school performance going down. So all of this can be a symptom of depression in children and adolescents. Now, let's say initially for children with depression, you can give a try with cognitive behavioral therapy, which is talking to a psychologist. Let's say psychologist therapy is not helping. What is the best mode of treatment for a child who has depression? Giving you a little bit of clue, depression, the best medication is SSRI. So SSRI is all of those that you might remember. So it's citalopram, sertraline, paroxetine, fluoxetine, fluvoxamine. So all of these are SSRI, which are commonly used antidepressant. Now tell me one thing, that if you need to give antidepressant to an adolescent, which one of these is your best choice? Very good, Dr. Adis, Dr. Sabrina. Fluoxetine or fluvoxamine, that's the best treatment of choice for children with depression, which means always you start with cognitive behavioral therapy. If cognitive behavioral therapy is not helping, then if you need to give an antidepressant in an adolescent or child, fluoxetine or fluvoxamine will be your ideal choice. What is this recurrent brief depression? So there is a term like this. If a patient has these recurrent episodes of depression, which is short duration, just maybe 3 to 7 days, and it happens every month. So you can't tell them as major depressive disorder. Why? because to diagnose MDD, symptoms needs to be there for at least 2 weeks. So if someone is getting a brief depressive episodes occurring every month, that is what we call as recurrent brief depression. In these patients, antidepressants are not that effective. For them, lithium is an alternative medication, but initially you are supposed to start with psychotherapy like CBT. So initial treatment is CBT, but if you need to give a medication, not SSRI, rather lithium will be your ideal choice. Seasonal affective disorder, not very important. Just remember, seasonal affective disorder means in case of winter, when everything is bleak and dark, these patients can get a little bit of depressed in winter. So this is also called winter blues. Not very important, but remember that if someone just getting depression during the winter time, the term is seasonal affective disorder. Treatment is psychotherapy, phototherapy, or even medication like SSRI. Now, important to understand how to manage a patient who has depression. So, as I said that if it is a mild to moderate depression, your ideal choice will be to start with psychological therapy. The best psychological therapy that we have got is called cognitive behavioral therapy, which is done by a psychologist. So what psychologist does in this case, that they listen to the patient and they try to motivate the patient and try to convert their negative thoughts into something positive. So that's more or less like a counseling. There are lots of other psychological therapy like interpersonal therapy, psychoanalytic or psychodynamic therapy. Okay, so those therapy are also important, but the best therapy is CBT. If you get CBT in the question, that's the first thing that you will always choose. We will discuss about those other therapies in our course when we again do the psychiatry class. So mild to moderate, your first line treatment is CBT. In your exam, many times you will find two different kind of questions. One, what is your initial choice of treatment? Or they can ask you, what is your next choice of treatment? They can ask you, what is the next most appropriate treatment? All of these are same. So initial, next most appropriate, everything means what's your initial treatment. But if the question asks you, what is your best treatment? Or what is your most appropriate management for this patient? That means what's your definitive treatment for this patient? Okay, so it is a little bit different how the question asked in the exam. You will have to think in that way. So the question can be very tricky in the exam, and always read what they're asking from you. Are they asking from you the initial treatment or the most appropriate or best treatment? Because answer is different. So let's say a patient who has got moderate or mild depression, what is appropriate treatment? Psychological therapy like CBT. For someone who has severe depression, for them, initial as well as the most appropriate treatment is antidepressant, and with antidepressant, adjunctive treatment will be CBT. So that's why understanding how to differentiate between these two is important. So for severe depression, the choice of treatment will be antidepressant, especially the SSRI, plus cognitive behavioral therapy. Then the last option, especially if it is a psychotic patient, severe depression, sometimes even electroconvulsive therapy. Now, have a look on this question first, and we will discuss that what's important and what's not important. So far you understand how to manage a patient with depression. So you have got a 72-year-old man comes to your clinic because of worsening depression and insomnia since his wife died 7 months ago. The patient experienced lethargy, tearfulness, has little interest in socializing with his married friends. He has attended 3 sessions of psychotherapy. However, the patient continues to feel depressed and experience severe insomnia. He has difficulty falling and staying asleep. He feels very guilty about her death. The patient experienced a moment of severe depression last week in which he briefly thought of suicide. However, he asserts adamantly that he would never act on those. Physical examination shows loss of weight. Which of the following is the most appropriate next step in the management of this patient? So, have you got all the criteria for major depressive disorder in this patient? Have a look. So, you have got a patient who is lethargic, so that's lack of energy. Tearfulness means depressed mood or sadness, loss of interest, right? You have got insomnia, you have got guilty, suicide. So at least 1, 2, 3, 4, 5, 6. So it's at least 6 out of the 9 you have already got. So this is a major depressive disorder. What's your most appropriate next step for this patient? So you want to increase the frequency of psychotherapy, prescribe amitriptyline. So amitriptyline is tricyclic antidepressant, and continue psychotherapy. Prescribe mirtazapine. Mirtazapine is a kind of a atypical antidepressant, you can say, or newer antidepressant. Continue psychotherapy. Prescribe zolpidem for insomnia and continue psychotherapy. Zolpidem is again a newer benzodiazepine for sleeping. Provide reassurance and continue psychotherapy. Recommend electroconvulsive therapy. So this patient already has tried psychotherapy. Still patient is undergoing severe depression. And that means this patient needs further treatment. So treatment means you need to add medication in this patient. So what medication you are going to add? If you follow the exclusive method of getting into the question, first rule out which is unlikely to be your answer. So psychotherapy only is not your answer. We never give zolpidem like any benzodiazepine for a depressed patient. Prescribe reassurance, like provide reassurance only will not help. ECT is still not our choice. So you have B and C as your likely answer. So which one you will choose? Are you going to choose amitriptyline and psychotherapy, mirtazapine and psychotherapy? Now remember, tricyclic antidepressant is not our not our first line option. That's our second line option. We try not to give tricyclic antidepressant in an elderly patient. Do you know why? Anyone? First, tricyclic antidepressant can make the patient very dizzy and they can fall. Second, tricyclic antidepressant can cause urinary retention and followed by incontinence. So it's very common to get urinary tract infection from retention of urine in these elderly patients. So we try not to give this in tricyclic antidepressant in an elderly patient. Even if it is a young adult patient, TCA is our second option. What's our first option in here? Mirtazapine. Mirtazapine is, after SSRI, mirtazapine is one of your best options. So you have mirtazapine, venlafaxine, desvenlafaxine. Those are newer antidepressants. Or also we call the venlafaxine, desvenlafaxine as SNRI. So SSRI is those citalopram, those things. And the SNRI is your venlafaxine, desvenlafaxine. The newer one is your mirtazapine. So if you don't have any SSRI in this case, then you go to newer or SNRI. In here, we can't see any SSRI in the option. If SSRI was in the option, we would choose that. But in here, mirtazapine will be our best option. Mirtazapine also is a very sedative kind of drug. Patient having sleeping problem like severe insomnia, So mirtazapine will help with the sleeping as well. So it's a very good antidepressant for someone who is struggling to sleep and having ongoing severe depression. Okay, clear everyone? Now, let's talk about side effects of the common SSRI medication. Almost all SSRI gives you nausea, change in appetite. They can also give you dry mouth, sedation, insomnia, headache, and lots of other findings you can get. If you look over here, these are the common SSRI. Fluoxetine, citalopram, citalopram, sertraline, paroxetine, fluvoxamine. And almost everyone has similar kind of side effect. So headache, insomnia, dry mouth, sexual dysfunction, those are common. Now question comes in the exam from these side effects a lot. You need to learn about the common psychiatric medication side effects, because in exam, pharmacy, especially the side effect, is a very commonly asked questions. So I will show you two common scenarios that come in the exam. One scenario is let's use this page. So let's say you have got a patient who you started with sertraline. All right. And you have started sertraline, let's say, just in a month time. So about a month ago, you started the patient with sertraline, and patient is on 50 milligram sertraline. 50 milligram is the lowest dose of sertraline, and sometimes you can go up to 100. So sertraline 50 milligram for a month. And now the patient started to have severe abdominal pain. There is no other cause of abdominal pain except the sertraline. What are you going to do? Anyone? Very good, Dr. Napal. So yes, what we normally do if a patient has got sertraline induced or any antidepressant, especially SSRI induced GIT upset, we will change this SSRI to another SSRI. So if patient having problem with sertraline, you can start the patient with fluoxetine. All right. Now, are you able to just directly change the medication, like you stop sertraline immediately and start the patient with fluoxetine? No. There are ways that how we do it. So normally, if you need to change an antidepressant, especially if a patient taking it for more than 4 to 6 weeks, you're supposed to gradually reduce the dose and then stop. So you can ask this patient to take half of the sertraline for another 2 weeks and then stop. Are you able to immediately start the new antidepressant? No. The reason behind it, if you stop a antidepressant, that effect can stay in the patient's blood for at least few days. Depends on what medication patient was on. At least 4 to 7 days, that effect can be there in their blood. So there is a guideline how much time we are supposed to give in between switching one antidepressant to another. So let's say you have gradually tapered the dose of sertraline and then you stopped it. You give at least a few days washout period. So that's what we call as washout period. So you give 2 to 3 days, no medication at all. And after 2 to 3 days, the effect of sertraline will be gone. And then you start fluoxetine. You start with low dose and then gradually increase the dose based on the patient response. So that's how we are supposed to switch one antidepressant to another for everything. Okay, is this clear for everyone? Great. Now let's give you another question. You have got a patient who is on sertraline, 100 milligram for 3 months. Patient's depression is well controlled with this dose. But over the last few months, patient is suffering from severe sexual dysfunction, and it's very severe that their marriage is now on the broke. That means you need to do something for this patient. What are you going to do? So this is a tricky question. So the first question that we have discussed, GIT upset due to sertraline. Every SSRI has a different kind of side effect profile, especially in terms of GIT upset. So one can give GIT upset, the other SSRI may not be causing that much GIT upset. So that's why we can change to another SSRI. But sexual dysfunction is common in every SSRI. So it doesn't matter if you change from sertraline to fluoxetine, sexual dysfunction will be more or less same for every SSRI. So it doesn't matter if you change it to another SSRI. So what we normally say, there are few things that can be done. The step one, if a patient is on a higher dose and their symptom is well controlled, the first thing you can do is to reduce the dose and see that if the symptom is gone and the depression is still well controlled. So that's the best option. But if the patient was on 50 milligram, then you could not reduce the dose, right? So then what would you do? Then the other option is that you can change this SSRI to newer antidepressant. And the newer antidepressant, which is better, is mirtazapine. So you can change it to other antidepressant in different group. So you can't change it to SSRI to SSRI. So you have to change SSRI to another group of antidepressant. Okay, either newer or even SNRI, or you can even go to the tricyclic antidepressant, those things. So different group. Third option is that you can add something for erectile dysfunction, like you can prescribe the patient sildenafil like Viagra. So that's your last option. But these are the first thing that you are going to try first. Okay, so both of these two questions appear in the exam in different ways. So you need to have a good idea on it. I hope that it's clear for you. So that's your SSRI side effect based question. Dr. Asbar, if patient is taking 100 milligram, can we change it to newer antidepressant? No, it's not needed, because changing antidepressant is difficult, and it also, there is a risk that this antidepressant is making the patients well controlled. The other antidepressant might not do that. So it's a more risky thing. So we will always do a reduction of dose in those cases. Mirtazapine side effect. Mirtazapine, as I say, that it causes severe sedation. It can cause constipation, drowsiness. It can increase weight, serum cholesterol, increase appetite, dry mouth, and sometimes even decrease appetite. But more common is sedation, drowsiness. Next is venlafaxine and desvenlafaxine. Those are called SNRI. Commonly, venlafaxine is known as Effexor in Australia. And it's a very commonly given medication. So side effect of Effexor is also important to know. So nausea, vomiting, headache, anxiety, those are very common. Mirtazapine causes sedation, whereas venlafaxine causes insomnia in most of the patients. So someone who is struggling with severe insomnia, venlafaxine is usually not a best option. It can also cause ejaculatory disorder, sweating, dry mouth. Those are common. This is one of the antidepressants which can cause weight loss because almost all the SSRI increase weight. So if someone coming to you and ask you that, I know every antidepressant increase weight, can you give me something which can reduce the weight a little bit? That will be your venlafaxine. The serious side effect of venlafaxine is that it can increase the blood pressure. So we are not supposed to give it in a patient who has uncontrolled hypertension. We are not supposed to give it in an epileptic patient. And also, venlafaxine commonly can cause hyponatremia. So if a patient is on venlafaxine and coming to you with confusion, delirium in an elderly patient, think about venlafaxine causing hyponatremia. So check their electrolyte level at that time. Okay. So as you can see that when I'm discussing a theory, I'm also going through the questions, which is important. Like if you know what questions are coming, then the theory becomes more interesting. Next is serotonin syndrome. So serotonin syndrome is one of the rare side effects of SSRI, but it's one of the serious adverse reaction. So if someone taking increasing dose of SSRI or they're taking multiple SSRI at the same time. So SSRI, it can include, so anything which increase serotonin in someone's brain. So antidepressant, all antidepressant, so SSRI, tricyclic antidepressant, SNRI, all antidepressant increase serotonin in your brain. Opioid, especially tramadol, any illicit drug like ecstasy, any of those, antiemetics like metoclopramide, lithium, selegirin. If a patient is on multiple medication which increase serotonin in their brain, they can present to you with this serotonin syndrome. So let's say that you have started a serotonin antidepressant, like let's say you have started citalopram in a patient 4 weeks ago. That patient went to another GP for same depression, that patient is very depressed, but she did not tell that she was on an antidepressant already. So the new GP has prescribed another SSRI, let's say fluoxetine. Now the patient is taking citalopram and fluoxetine both. So that's one of the risks. Or patient took multiple SSRIs at the same time. Like patient took 3 tablets of escitalopram by mistake. Or patient on antidepressant went to a party and then took a lot of stimulant drug. So these are the common scenario of having serotonin syndrome. So how usually these patients present? A patient who has serotonin syndrome, they can have CNS symptom, they can have muscular symptom and some autonomic symptom. So CNS, they can have mental status change, so they can get very agitated, confused. They can also get seizure. Muscle related, they can have tremor, shivering, myoclonus, and hyperreflexia. Very important finding. And autonomic, they can get hypo or hypertension, tachycardia, very sweaty, fever, diarrhea. If you look on this patient, that's how serotonin syndrome patient presents. So their pupil will become dilated. So dilated pupil, diaphoresis or sweaty, agitated, increased bowel motion causing diarrhea because of autonomic hyperactivity. Same tachycardia, hypertension because of autonomic instability. They can get hyperreflexia, tremor, and clonus. So these are the findings of serotonin syndrome. If you get a patient with serotonin syndrome, your treatment is immediately stop any medication which increase serotonin in their blood. So in those situations, you don't need to gradually taper the dose and then stop it. You immediately stop it and then treat the patient symptomatically. How to differentiate between serotonin syndrome and another complications called neuroleptic malignant syndrome. So these are the two conditions. You already know that serotonin syndrome is because of a patient who is on antidepressant. But neuroleptic malignant syndrome is mainly a complication for someone who is on antipsychotic medication. So how to differentiate between these two? Serotonin syndrome usually comes very abruptly, neuroleptic malignant syndrome gradual. The main difference is neuromuscular finding. NMS, so neuroleptic malignant syndrome, they get diffuse rigidity of their whole body, but in case of serotonin syndrome, they get tremor and myoclonus. Reflex will be increased here, decreased in NMS. Pupil will be dilated in serotonin syndrome, normal in NMS. So that's how we normally differentiate between these two. Coming to continuation of treatment. Let's say you started a patient with antidepressant. How long they're supposed to take it? First of all, a patient comes to you after starting a SSRI for 2 weeks that doctor, my depression is still very severe. I want to change the drug. Do you change the drug after 2 weeks? No. You at least give 4 to 6 weeks to get the benefit from the antidepressant before you change it to another medication. So it at least needs 4 to 6 weeks to do its effect on someone's mood. Once you have done for 4 to 6 weeks, still patient is severely depressed, changing it to something else. Now let's say you have continued one antidepressant. They're supposed to continue it for a minimum of 12 months if this is the first episode. But for someone who gets recurrent depression, for them at least 2 to 3 years. In some guideline, they say 3 to 5 years. Okay, so that's all about depression. As you can see, guys, that it's just a single topic. And how much information you might need to have for your exam. So to understand things, you need to go a little bit detailed. But to get an idea about everything that I have discussed this time, it needs a long time preparation, long time experience. So you don't need to do that by yourself. We are here for helping you to understand those things, and we can show you the correct way so that you don't waste a lot of time to prepare for the exam. All right. So I understand that your brain becoming a little bit foggy now. Let's take a 10-minute break, and then we move on to psychiatric conditions, especially bipolar disorder and psychosis. Okay, so let's take a 10-minute break. Thank you. If you have any questions about depression, you can write it in the chat box. Thank you. All right, everyone, let's start the class again. So, Dr. Shani, you asked about the duration of the class. So we normally take class for 2 hours. So tonight, it might be a little bit more than that. So 2 hours, 15 minutes. Dr. Rumana, in that scenario, which drug should be ceased immediately, sertraline or tramadol? Both. Anything which increase sertraline should be stopped immediately. Let's continue, and then if you have any questions about AMC MCQ preparation, we will go through that at the end of the class. Okay. So bipolar disorder. So bipolar disorder, it's looking like this. So if you think that this is the baseline mood of a patient, sometimes they go into the depressive phase, that's depression. Sometimes their mood becomes hyper elevated, and that's what we call as mania or manic phase. If someone has got these mood swings, has both mania and depression time to time, they are known as bipolar disorder patient. What is the criteria for manic episode? We have divided bipolar into mania and hypomania. So it's also important to understand how to differentiate between these two. So DSM-5 criteria says, if someone has got at least a week of abnormally elevated mood, with that, 3 or more of the following: inflated self-esteem or grandiosity. So they think that they have high superpower, or they think that they have very high self-esteem. They have decreased need for sleep. So very energetic. They don't even think that they need to sleep. Talkative and accelerated speech. Racing thoughts or flight of ideas. Very distracted. Increased goal-directed activity, and excessive activity with painful consequence. If 3 out of these 7 symptoms persist for at least a week, which causes significant impairment in their social occupational life, that is what we will call as mania. How to remember it? We have a mnemonic called DICFOST. So D for distractible. Patient with mania will be poorly focused. They will involve themselves in multiple activities, and they will not be able to finish any of those activities. So they will jump from one topic to another, very distractible, like they will involve themselves in a lot of activities at the same time. Insomnia, especially they have a decreased need for sleep. G for grandiosity, which is inflated self-esteem. They think that they have superpower. They think they are going to win the Nobel Prize. They think that they are going to achieve everything in a few weeks or months. F for flight of ideas. Flight of ideas is a very important finding for mania. So what they do is that they jump from one topic to another. So that's what we call as racing thoughts. Activity, increased goal-directed activities. Someone who is always nice and calm, suddenly they have enrolled themselves in multiple clubs. So they have enrolled them into swimming club, maybe foreign language club. They have enrolled themselves in gym. So a lot of goal-directed activities. That's one of the other features. Speech will be loud, talkative, and pressured. Thoughtlessness. They also take a lot of risk activities like reckless driving. They involve themselves in a lot of financial risk and also reckless sexual activities. So that's what we call as mania. Let's have a look now how to differentiate mania with hypomania. Hypomania will have all the symptoms that we have discussed, but it will be less intensive, which means the duration will be less than a week and the symptom will not be severe enough to disrupt their social or occupational life. That's hypomania. There is 2 kinds of bipolar disorder, bipolar 1 and bipolar 2. If a patient has mood disturbance in which patient typically experience symptoms of elevated mood for at least a week. So if a patient has got mania plus depression, that's bipolar 1. Hypomania plus depression, that's bipolar 2. So have a look on this bipolar 1 condition. A 19-year-old college student is taken to the school counselor after he fails several classes. Patient enrolled in numerous classes, most of which have conflicting times, so increased goal-directed activity. Grades are poor, yet he seems undisturbed by this. He is also enrolled in numerous organizations such as chess club, drama club, student government, sports, and at least 2 fraternities. Speech is pressured and has psychomotor agitation. So that gives you the diagnosis of manic episode. All right. So we say that bipolar 1 has one fully fledged manic episode, at least one manic episode in their life. Bipolar 2 usually has major depressive disorder with some hypomanic episode. Typical behavior we already know: reckless behavior, overspending, hasty decisions like hasty marriage or job resignation, impaired judgment, increased sexual drive, increased energy, lack of sleep, all of them. How to manage a mania patient? Very important for exam. Mania is a medical emergency and every manic patient should be hospitalized for protection of themselves and others. If a patient with mania does not want to get admitted, you can do involuntary admission for them. So normally we are not supposed to keep a patient in hospital without their consent. But there are some areas where involuntary admission can be applied. So especially if a patient is risky for themselves or others, then even if they don't give consent to get admitted in the hospital, you can do involuntary admission for them. Meta-analysis indicates that antipsychotics are the most efficacious drug. So what is the most effective treatment for acute manic episode? Antipsychotic. What kind of antipsychotic? The first line is olanzapine or risperidone. Commonly, we use risperidone in Australia and then olanzapine. So the first line in acute manic episode is any of the second generation antipsychotic or atypical antipsychotic, which is your risperidone or olanzapine. What are the second line? Haloperidol is your second line treatment. Lithium, any mood stabilizers like sodium valproate or carbamazepine. So these are your second line treatment for mania. Let's say a manic patient is very aggressive and agitated that he doesn't want to take oral medication. For them, your choice will be to give haloperidol IM or IV. So manic episode, but having severe aggression, aggressive agitation, then oral medication is not the choice. Choice is IV or IM. So the first line treatment for acute mania is antipsychotic, especially not the typical antipsychotic. Typical antipsychotic is haloperidol. That's your second line option. Rather, atypical antipsychotic will be your first option. Now, if someone has got recurrent bipolar disorder, for them, especially someone who has got 2 or more episodes of mania or depression in the last 4 years, for them, we go for maintenance treatment or prophylactic treatment. So what is the maintenance treatment for bipolar patient? That's lithium. So lithium will be your best treatment as a maintenance treatment. If lithium is not available, then any of the second generation or atypical antipsychotic you can try, like olanzapine, risperidone for a long time. Or even you can try some mood stabilizers like carbamazepine or sodium valproate. Okay, so that's your prophylactic agents for bipolar disorder. If a patient is on lithium for a long time, we need to make sure that they don't get lithium-induced toxicity. So we have to check their lithium level regularly to check that if the lithium is not getting toxic level. The reason is that lithium has a very specific dose that we need to always go for, and their therapeutic index is very low. So chance of toxicity is very high in a patient who is on lithium. So check the lithium level if any kind of toxic symptoms you get. So what are the side effects of lithium? Tremor, muscle weakness, weight gain, GIT upset. They can cause hypothyroidism and nephrotoxicity. The mild toxicity, usually GIT upset, so nausea, vomiting. They can also cause tremor, hyperreflexia. Moderate, if a patient gets hypertonia and hypotension and rigidity. Severe means if cardiovascular collapse, like patient getting into hypotension, tachycardia, or patient having severe CNS manifestation like seizure, coma, that's severe. Why we are discussing this is that treatment of lithium toxicity come in the exam. And it depends on the severity. If a patient has got mild to moderate toxic symptom, the best option is just IV hydration. So IV fluid will be your choice. If a patient has got severe lithium toxicity, let's say someone has got cardiovascular collapse or seizure, coma, in those situations, especially if a patient has got cardiovascular collapse or renal failure, dialysis will be your ideal choice. Or also sometimes if lithium level is more than 4, they usually will give you severe toxicity. For them, dialysis is your most effective treatment. So this comes in exam, okay? Now the next topic is bipolar depression. The tricky case in this bipolar depressive patient is that a patient can come to you with just depression feature. You never know that if this patient also has some history of mania. Maybe only depression is still the feature. Once you started antidepressant, that can precipitate a manic attack if a patient has bipolar disorder. So you can't avoid that, but always in your history, when you ask about depression, find out if the patient had an episodes of mania or hypomania in their previous few years. Because in those situations, you can't just give them antidepressant, you have to give them both antidepressant and a mood stabilizers. If you give only antidepressant, you will just precipitate an attack of mania in that patient. So bipolar depression is a difficult component to treat, and antidepressant should not be used alone. In those situations, we say start with a classic antidepressant like SSRI and add a mood stabilizer, anything like lithium, valproate, carbamazepine, quetiapine, anything you can use, but at least you'll have to use something. Antidepressants are usually stopped within 1 to 2 months, and then you just continue the patient with mood stabilizers. All right. So treatment of bipolar depression is different than treating just a depressed patient. Another question for you. A 27-year-old man is brought to the office by his wife due to her concern that he hasn't been himself for the last 3 weeks. She says that he's depressed and withdrawn, sleeps 14 hours a day, has no energy or interest. The patient was hospitalized 6 months ago for an episode in which he became aggressive toward his wife. This occurred when she confronted him about staying up all night, gambling away their savings, investing a large sum of money in a startup internet company that went bankrupt. At that time, patient spoke very rapidly and convinced that he had a brilliant plan to achieve world peace. He also had a similar episode 2 years ago. Which of the following medication are the most appropriate maintenance treatment for this patient. So this is a bipolar depression patient, right? So previously he had a manic episode. Now patient is depressed. What are you going to do for this? Carbamazepine, fluoxetine, lithium quetiapine, lithium sertraline, lurasidone risperidone, valproate clozapine, valproate haloperidol. Now rule out the unusual things. We don't give, so risperidone is the antipsychotic, lurasidone is the antipsychotic. So you are not giving both antipsychotic in a patient, so cross that. Valproate is a mood stabilizer, clozapine is an antipsychotic, but they're the same mood stabilizer category. So again, it's not your choice. Same with valproate and haloperidol, they are mood stabilizers. You have got carbamazepine and fluoxetine. So that's fluoxetine is antidepressant, carbamazepine is a mood stabilizer. So that's one option. Lithium and quetiapine, both of them is mood stabilizers. So again, not needed. Lithium and sertraline, so that's a mood stabilizer and an antidepressant. So you have A and C as your option to choose. Which one is best? Best is lithium, because lithium is your best prophylactic medication or maintenance medication. So you will use lithium, and for depression, you will start sertraline. Okay, so your answer is C. So see that why understanding these questions are important, because if you don't understand, you will never know what to choose in the exam. And psychiatric questions can be this much big. So you will need to get an idea how to get the most important things from a question. We discussed about persistent depressive disorder, which is also known as dysthymia, which is a depressed mood for at least 2 years, but it's a mild, severe depressed mood. There is another condition called cyclothymic disorder. Cyclothymic disorder is basically a patient who has depression with many hypomanic episodes lasting for at least 2 years. So if someone has got a bipolar 2 disorder, having hypomania and depression, but continuous for 2 years, that's cyclothymia. Time to time in your AMC exam, you will find out a topic which we call grief or bereavement. Understanding grief or bereavement is very important because you will get confused in the exam otherwise. So grief is a very common psychiatric issue, especially if a patient lost their loved ones. Everyone goes through the grief process. It's a natural part of human being. And grief symptoms are pretty much same like depression. So they get very sad, gloomy, tearful. They have trouble to sleep, decreased appetite, decreased interest. So a lot of their symptoms go with depression symptom. But we don't diagnose them as depression. We say it's just a normal grief or bereavement. Grief usually starts to get better within 6 months, but depression can persist months and months. In case of grief, symptoms wax and wane. So sometimes it just gets better, sometimes get worse. Guilt is less common, but guilt is more common in a depressed patient. Patient who has grief usually returns to baseline within 2 months, but maximum 6 months. Anyone who has got grief symptoms lasting more than 6 months, the term becomes complicated grief or complicated bereavement. Okay, so this term also comes in the exam. So 6 months is the maximum time a patient can have the grief symptom, but after that, if still they have that, that's complicated grief or bereavement. The treatment for grief is counseling, whereas depression treatment includes counseling or antidepressant. We don't give antidepressant in a patient who is just having grief. Let's move on to schizophrenia. Schizophrenia is a very important topic for your exam, and a lot of things is important to understand from here. So basically, schizophrenia means a psychotic patient who has lost their reality or who has lost touch with the reality. Schizophrenia is associated with high level of dopamine and abnormality in serotonin. So there is some chemical imbalance in the pathophysiology of schizophrenia. It's more common in low socioeconomic status, and there are some risk. So this risk comes in exam. General population 1%, monozygotic twin 47% risk, dizygotic twin 12%, one schizophrenic parent 12% risk that their children will have schizophrenia, two schizophrenic parent 40%, one first degree relative 12%, second degree relative 5 to 6%. So sometimes they ask you that you have got a patient who is coming to you to know the risk of schizophrenia because his grandmother had schizophrenia. So grandmother is second degree relative. So what's his risk of developing schizophrenia? 5 to 6%. Okay. So this type of question also comes in exam. Diagnosis of schizophrenia. There is a criteria on which we diagnose a patient of schizo. So if a patient has got at least one of these three, hallucination, delusion, and disorganized speech, and two or more of the following for at least 6 months, that's when we call them as schizophrenia. So two or more of these 5 symptoms, but at least one from these 1 to 3 for a 6 month, that is schizophrenia. That means a patient needs to have hallucination, delusion, disorganized speech, disorganized behavior, and negative symptoms like flat affect. If at least 2 or more of them are present in a patient for 6 months, then we diagnose them as schizo. What is delusion, what is hallucination, and what is disorganized speech? Delusion is an abnormal belief that even after you have given appropriate explanation about the belief, still patient stick to their belief. Delusion can be a lot of delusion. So something can be paranoid delusion. So patient thinks that someone is trying to harm themselves, someone is trying to poison themselves, someone is spying on themselves. That's what we call as paranoid delusion or persecutory delusion. Then there is delusion of reference. Patient thinks that someone in the street always talking about him. Neighbors are always talking about him. People in the street always talking about him. That's delusion of reference. Delusion of control. Patient thinks someone is controlling his thoughts. Delusion of guilt. Patient thinks that he is guilty about someone's death. Delusion of grandiosity. Patient thinks that patient is a messenger of God and fire cannot touch the patient. So that's delusion of grandiosity. So these are different delusions that you can get in the exam. What is hallucination? Patient is seeing something or hearing voices or can feel insects crawling on their body, but there is nothing. So the seeing something is visual hallucination, which is common in alcohol withdrawal patient or also schizo patient. Hearing voices is auditory hallucination, and feeling insects or feeling something crawling on their body, that's tactile hallucination. Then you have got disorganized speech. Like if you don't understand what a patient is saying, that's disorganized speech. Disorganized behavior, patient is unkempt, not well groomed. patient looks very disorganized. That's disorganized behavior. Negative symptoms. Patient did not going outside their room at all. If patient stopped talking to someone. So this withdrawal behavior is negative symptoms. So these are the symptoms in a schizophrenia patient. We divide schizo symptoms as positive and negative. Positive means something a normal person doesn't have, but a schizo patient have it. So they have delusion, hallucination, thought disorder, or disorganized speech and behavior. Negative means a normal person has it, but schizo patient doesn't have it. So they have flat affect, so they don't care about anything, poverty of thought, lack of motivation, social withdrawal, reduced speech output. So these are common symptoms of schizophrenia. Coming to the management of schizo. Main management is drug. So you have to treat them with medication. Psychotherapy is not the treatment. What is your typical choice of treatment for a patient who is schizophrenic? The typical initial treatment will be the second generation or atypical antipsychotic, which is your olanzapine or risperidone. If both of them are in the option, you choose risperidone because this is commonly given in Australia. If response is inadequate in 3 weeks, then you can increase the dose according to the guideline. If there is no response after 4 to 6 weeks, change it to another second generation. What are the first generation antipsychotic? Chlorpromazine, haloperidol, triflupragine. We no longer use these medications. Haloperidol is still in use, especially sometimes patient might be very aggressive, especially psychotic patient. In those situations, they will not ask or they will not take oral medication. You have to give something IM. So if a patient who has acute psychosis and very aggressive, in those cases, you can try haloperidol IM, olanzapine IM. These are the most commonly 2 IM medication that we have got. Okay. So it depends on what kind of antipsychotics you are giving to the patient, and you find out if the patient is responding to it. There is a condition called drug-resistant schizophrenia, which means that you have tried 3 antipsychotics in their maximum dose. Still, the schizophrenia is not well controlled. In those situations, we call it drug-resistant schizophrenia, and the treatment of choice is clozapine. Clozapine is our last resort in this patient. Clozapine is one of the most effective antipsychotic, but it is also one of the highest side effect antipsychotic. That's why we keep it as our last resort. The side effect of clozapine is that it can cause blood dyscrasias. That means you can get leukopenia, neutropenia, you can get, most of the time you can get neutropenia in this patient. Cardiotoxicity is the most important complication of clozapine. Let's say you have started a patient with clozapine and coming to you with a chest pain. What is your most likely diagnosis? Most likely diagnosis is myocarditis, which is a common complication for clozapine. What you need to do, you do a ECG and you do the troponin, and then you do an echocardiogram of the heart. If clozapine causes blood dyscrasia or cardiotoxicity, you are supposed to stop clozapine. If a patient doesn't respond to clozapine, the last option is electroconvulsive therapy, ECT. Okay. So these are the main medication that we use in a schizophrenia patient. So olanzapine, then risperidone. There are also lots of other antipsychotic we will discuss just in a bit. Before that, you should know about the side effect of this antipsychotic medication. It comes in exam in many ways. So common side effects of antipsychotic is acute dystonia. So patient with antipsychotic medication, if they come to you with a bizarre muscle spasm of their face, neck, tongue, and trunk, so just little bit of muscle spasm, that's acute dystonia. Treatment, add benztropine along with the antipsychotic, that will help. You don't need to stop antipsychotic for it. Akathisia. Patient will say that recently you have started antipsychotic in this patient and they can't sit. They're always restless, and especially restless foot and restless leg. That's akathisia. Two things you can do. You can reduce the dose of antipsychotic, or you can use any of the propranolol, diazepam, or benztropine in this patient. But reduction of the dose is the best idea. Another complication, which is very important, comes in exam is Parkinson-like side effect. So patient with antipsychotic, they can come to you with a Parkinson symptom. So they can have a Parkinson gait. They can be very slow to start walking, so bradykinesia. They can have resting tremor. So especially motor Parkinsonism symptoms. So they get a Parkinson-like gait. In those situations, you can lower the dose or you can use benztropine in this patient. Then you have tardive dyskinesia. Tardive dyskinesia means abnormal involuntary movement of face, mouth, tongue, and limbs. Usually happens if a patient takes antipsychotic for a long time. So they get kind of like an involuntary movement of their face, mouth, or tongue. First of all, if you get tardive dyskinesia, the best option is to stop the medication. And if that doesn't help the patient, you can use tetrabenazine in this patient. This was that neuroleptic malignant syndrome. Remember, it usually happens at any time. Even if you just started yesterday, patient can get neuroleptic malignant syndrome today. Patient with neuroleptic malignant syndrome presents to you with high temperature, muscle rigidity, and altered consciousness. You stop the medication and treat the patient with IV fluid. If it is life-threatening, then you can give something which can increase dopamine in their blood, which is bromocriptine or dantrolene. All right, so that's the treatment, and that's how we differentiate the side effects of this antipsychotic medication. So if you go through this again, acute dystonia is bizarre muscle spasm. Akathisia is restlessness. Parkinson, you know that it gives you the Parkinson-like gait. Tardive dyskinesia is involuntary movement. And neuroleptic malignant syndrome is fever, muscle rigidity, and altered mental status. Now, most important topic for today: side effects of common antipsychotic medication. A huge number of questions come from here. So these are the common second generation antipsychotic that we use. So common one is aripiprazole, clozapine, olanzapine, quetiapine, risperidone. And then there is ziprasidone. So remember this name, because if you don't know the name, then you don't know what the question is all about. Let's start with olanzapine. Have a look that olanzapine causes dyslipidemia. They can cause hyperglycemia, so diabetes. They are also very sedative and can cause weight gain. So mainly metabolic syndrome. So weight gain, hyperlipidemia, diabetes. Same with the quetiapine. It causes dyslipidemia, hyperglycemia, sedation, weight gain. So more or less same side effect. Clozapine also same. Clozapine has the highest side effect, causing dyslipidemia, hyperglycemia, sedation, weight gain. So these three, clozapine, olanzapine, quetiapine, they usually same side effect. Whereas risperidone, it gives hyperprolactinemia and orthostatic hypotension, but not that much of a weight gain or dyslipidemia in risperidone. So hyperprolactinemia means patient will come to you with whitish discharge from their breast, and they can have, especially for men, they will have lack of libido, and for female, they can develop amenorrhea or subfertility. So hyperprolactinemia is a feature of risperidone. Whereas if you look on aripiprazole, it has the least side effect. It doesn't cause dyslipidemia, doesn't cause hyperglycemia, doesn't cause sedation, doesn't cause hyperprolactinemia. But why don't we use this? Because it's also not very effective. Sometimes question asks you, what is the least effective antipsychotic? That's quetiapine. What is the most effective? Clozapine. Now let me give you two questions. One, you have got a patient who has been started with risperidone and now presented to you with the galacturia. What are you supposed to do? In such cases, you can change risperidone to aripiprazole because that has the lowest side effect of causing hyperprolactinemia. If aripiprazole is not in the option, then quetiapine. Okay, a patient has been started with olanzapine, but now developed weight gain and also getting diabetes. The first thing that you ask the patient to do is to do lifestyle modification. If that doesn't help, then again you can change olanzapine to aripiprazole. So these two questions come in exam, so please remember it. Okay, now quickly we will just discuss few psychotic disorders with you before we finish this class. Schizophrenia is diagnosed based on the duration of symptom, right? If a patient has got schizophrenia or psychotic symptoms for 6 months, that is what we call as schizophrenia. But let's say someone has got symptoms for less than a month. So if the symptom is less than a month, that's what we call as brief psychotic disorder. So symptoms more than a day, but less than 30 days, but all the same symptoms, that's brief psychotic disorder. Again, the treatment is same. If patient is having active hallucination delusion, hospitalization, and treat them with antipsychotic. What if someone has got symptoms which last more than a month, but less than 6 months? That's what we call as schizophreniform disorder. Same treatment. And more than 6 months, that's schizophrenia. There is another topic which we call schizoaffective disorder. This is a little bit complicated, but if you just divide schizoaffective, you can see that patient will have schizophrenia symptom and also affective symptom. What is affective symptom? Affect is your mood. So patient will have either depression or mania along with schizophrenia symptom. The symptom will be like this. Patient will have symptoms meeting criteria for major depressive disorder, manic episode, or mixed episode. Patient also will have symptoms for schizophrenia, and they will have delusion hallucination for at least 2 weeks in the absence of any mood symptoms. So right now, patient having both schizophrenia and affective symptom. But previously, they had it at least 2 weeks where they did not have any mood disorder, but only hallucination and delusion. That's schizoaffective disorder. Let's look on this question. It will give you an idea. A 25-year-old woman is found walking nude in the shopping mall. When asked why, she replies, "I am making it easy for others to have sex with me since I know they all want me." So that's a delusion. She states she heard a voice telling her she was irresistible and everyone wanted her. So hallucination, when she speaks, she can't focus on one topic at a time. So flight of ideas. Mood is euphoric, her affect labile. She recounts an episode last year. So this part is mania. She recounts an episode last year where, although she did not have any elevated or depressed mood, she heard voices she could not describe. So that was that, just a brief period of psychosis where there was no mood symptom. This symptom lasted for more than 6 months and caused her to lose her job. So did you guys understand how to get the diagnosis of schizoaffective disorder? When someone has got both schizophrenia and mood disorder, but there was a brief episode of psychotic disorder without any mood symptom, that's schizoaffective disorder. Hospitalization is the first treatment, and then use antidepressant plus antipsychotic in this patient, because they have both psychosis and also mania or depression. Treatment will be combination. So if a patient having schizophrenia and depression, then you start the patient with antipsychotic and antidepressant. If a patient has got mania with schizophrenia, then use antipsychotic with mood stabilizers. Okay. The last questions for today is delusional disorder, and then we stop today's session. So delusional disorder means that patient only has delusion or false belief. So patient will have a non-bizarre delusion for at least a month, but it will not do any impairment in the level of their functioning. So the main finding in delusional disorder that they have an abnormal belief, but that belief is not absolutely false. It can happen. So that's why we call it non-bizarre delusion, lasting for at least a month, but it will never affect their social, occupational, or familial life. And they will not have any other symptoms like no disorganized behavior, no hallucination. So have a look. Mr. Smith has been married for 10 years. During most of these years, he believed his wife was trying to poison him to get his money. He frequently complains of a stomach pain, which he believes is due to the poison in the food. His thoughts are logical and coherent. So no thought disorder, no hallucination. His wife, an independently wealthy woman, doesn't understand her husband's logic because she has more money than he does. So you can understand from this question that patient doesn't have any hallucination, doesn't have thought disorder. It's just that abnormal belief that he has. So that's delusional disorder, which has only delusion in it. For this kind of patient, management, usually you can give them antipsychotic medication or sometimes just some psychotherapy. Let's do some question. Let's see what you have learned. A 37-year-old woman is brought to the emergency department by police after she was found trespassing on a famous film actor's street. The patient is excited and says that this is all a big misunderstanding. She explains that she was only trying to leave the actor a surprise gift and a note and would never harm him. She recently received a signed photograph in response to one of her letters and keeps it in a box filled with newspaper and magazine article. Patient says, for now, we need to keep our relationship secret so his wife won't find out. Although she hasn't met the actor in person, she's convinced that they will be together someday. So that's a delusion. The patient has worked for many years as an administrative assistant. Although she has no difficulty performing her job, she keeps to herself as she feels that her co-workers do not understand her special relationship. She is calm and cooperative, not pressured, or her speech is non-pressured and goal-directed. The patient says, her mood is wonderful because I'm in love. Which of the following is the most likely diagnosis? Bipolar, manic, borderline personality, delusional disorder, narcissistic personality, schizoid, or schizophrenia? What do you think? Yeah, right? Because this is going on for quite a long time. So this is likely to be a delusional disorder. Because you can see here that she's not having no pressured speech. She has no difficulty performing her job. Okay, so it hasn't affected her life. The only belief is about her relationship with the actor. So that's delusional disorder. Okay, don't get complicated with manic episode, because manic episode will affect their job. Manic episode patient will have lots of goal directed activities, pressured speech, lot of other finding will be there. Okay, so that's all about tonight's session, guys. And this is how usually we take our sessions. I hope you learned something about psychiatry today, and you can use this throughout your life. Now, this is the time where we discuss about the course a little bit, and then we allow you to ask questions about it. So let me open our course detail. Just give me 1 minute. I will just stop sharing this, and then I will share another thing with you. So I guess all of you are our First Aid AMC MCQ Facebook group member. If you need any kind of course detail idea, so you go to this featured section, and after going to the feature section, you will always get the updated detail about the course. You can also go to our website. So the website link will be given at the end of this. So this is our website. If you go to the website, you should be also get our course detail, the subscriptions and everything. Now, let me discuss with you that how our course usually is supposed to happen. So the new batch is going to start from 30th April. Today is our trial class, but there will be another free 2-week session, which is starting from 2nd of May. The schedule of that free 2-week sessions will be given to this Facebook group. So keep an eye. The course is organized in a way that you have everything that you need to pass the exam in your first attempt. We have a very good software or a portal from where you get every materials that you need. So first of all, we are going to go through every theory that you need from John Mottag and some other guideline that you need. We also have a 5 years sample question discussion from 2018 to 2023. And we have a monthly update with 1 class every week just on question solvation. So you get 3 class with us every week. 2 class is based on theory, and sometimes we do theory-based question solvation. And 1 class every week, sometimes 2 class every week on recent question solvation. You get a software where you get all the mock test and all other material. And we have subjective mock test, we have month-wise mock test, and we have full mock test. And the access of the mock test will be there until you pass the exam. You get a Q bank, you get recording of every class, usually within 24 hours. So if you want to do an offline course and you can't join live session, then always you can do it by getting into the recording. Almost half of our students usually do the offline one, which means they can't come to the online class. They just go through the recording of the class and they finish the course in that way. That's absolutely fine. As long as you're going through the recorded classes, which is exactly same like this. But I always ask you to come to the live class if you can. The class is usually Sunday. Sorry, now we have changed the classes to Saturday, Sunday, and Tuesday. Okay, 8 to 10:30 is usually the time. We have also given all the discussion from where we do the classes and everything. You also get some extra classes on imaging, ECG, CT scan, CTG, STAT, ethics, fundoscopy, ABG, a lot of other free classes are there. Okay, so not only that, we also help you to find out about the job and registration and how to actually prepare yourself to become a doctor in Australia. So you get some classes on that as well. So this is all part of our first new course. And if you are a member of this group, you would be seeing here about all the reviews from all of our students, especially those who have passed the exam. And you can see that every month, a huge number of candidates who pass from our course. And all of them, usually we congratulate them here, and you can go through them. You can find out who are passing the exam, how is our passing rates and everything. And that will give you an idea about the course as well. Okay, so do you guys have any question about the course or about today's class? You can also unmute yourself if you want and talk to me. So that's totally fine. Yes, so you get a timetable or a schedule of the course, but the timetable is usually given after joining the course. So all the course timetable or schedule usually will be given, and your class schedules are always updated in the Facebook group. So once you join the course, we will add you to our portal and also to our Facebook course group, where you will be able to get to see all of those. The AMC exam, if you pass, it is lifetime. It doesn't get expired. Good question. How much time it takes to prepare for AMC? It's a subjective thing. It depends on a lot of things. That are you only preparing for AMC, or are you also doing job in your country? So if you're doing job, it is difficult to get a huge amount of time to prepare. But if you are just preparing for AMC, then usually 6 months is more than enough for your preparation and go for the exam. I would never say 3 months or 2 months for preparation, because that's absolutely not an ideal idea. If you have a lot of commitment, then at least 8 months will be your most likely time of preparation. Thank you, Dr. Azbar. So to join the course, either you can send an inbox to my messenger. So if you are in the First Aid AMC MCQ group, you will be able to get my ID. So you can just send me an inbox, or you can also send us an email. So our email ID is also given in every post in the Facebook group. But if you want, you can write it as First Aid AMC 4536 at outlook.com. So that's our email. If you send us an email and you say that you want to join the MCQ course, our team will help you in that. Okay. In which countries can we take AMC? In my knowledge, you can take AMC in Thailand, Singapore, India. You can take it in China and obviously in Australia, UK also. And I'm not very sure about other countries. The next session after April will be after 5 months. So basically it should be in October. Yes, so all the slides are sourced from JM and Kaplan. The class notes is not available for anyone who is not a part of the course. So Dr. Sadman, you get the slide of the lecture in your portal if you already have joined the course. So anyone who joined the course, you are asked to join our portal. So you will be given some time to just do the subscription in the portal. Once you have done that, then you will be able to get to see our class notes. Yes, Dr. Shani. So if you join the classes, the recordings will be available to revise in future. We allow you for total 10 months to get the video recordings. So even after 5 months course, you get another 5 months of this class recording to go through. And 10 months is more than enough for you to appear the exam. So that's more than enough that you will need the access. I'm not aware about Turkey, Dr. Anwar, that if you can appear from Turkey. Do we get access to all the videos at once if we join offline course and decide our pace accordingly? No. So because we only can upload the classes once we can take the class. We can't give you the video recordings of the class which is supposed to happen after 3 months. So that's not possible, right? Because the videos are just the live class recording. So we can only give you after the class is done. But if someone has got a placement in their exam, let's say you have got exam in 2 months, then you will not be able to finish our course. In that case, we give you the access to our previous batch recording, and you can go through our previous batch and finish it in your own pace. Okay, so any questions, guys? Now, obviously, you should be able to ask any questions in our free 2-week sessions as well. So just keep an eye on the Facebook group. You will get the schedules of free 2-week session. But to give you the idea, it's going to start from 2nd of May. So if you take the previous batch recording, then you can still join the new classes and get the new batch recording as well. But in those situations, you will need to show us that you have an exam placement already. And Dr. Judith, to contact, you can send me an inbox through the messenger. So if you are part of First Aid AMC MCQ group, then you can get my ID from there, or you can also send me an email. So the email ID is given over here. So that's firstaidamc4536@outlook.com. So you can also send us an email in that way. All right, everyone. So let's finish it here tonight then. I hope that you learned something from today and you enjoyed the session. Okay. If you want to start your preparation straight away, I would say that join the course immediately and we will be able to start giving you the portal subscription. And in between this 16th of April and 2nd of May, you still have 2 weeks. So these 2 weeks, you can start your preparation by going through the notes. And we also give some previous question solution videos in your portal already. So you can go through those questions as well. So if you are sure that you want to join the course right now, just ask us, send us an email, send me an inbox, and start your preparation with us immediately. Okay, so you don't need to wait for 2 weeks to be done. If you're sure that you want to join, you just reach us immediately. And if you are still not sure, you want to go through our 2-week session, please wait, because that's always a good idea. You can learn about us, you can see how we take classes, and then you can join as well. It's totally fine. Okay, so we'll finish it here tonight. The recording of this class will be given in the Facebook group as well, and also in the YouTube. So you can go through that if you want. Thank you, everyone. Take care. Have a good night.